Okay, so for this deep dive, we're looking at a really specialist role within the NHS, often kind of unseen, but absolutely critical. We're talking about the UK clinical coder.
That's right. And our goal here is to really unpack the skills needed because it's surprisingly complex, much more than just, typing data in.
Yeah, it seems they're kind of the linchpin for the whole system's data integrity, right?
Absolutely. Think of them as like translators of medicine. They take all the clinical notes, what happened to the patient, the diagnosis, the procedures, and turn it into standardized code.
Alphanumeric codes. Yep.
Exactly. And that data, that specific coded data, feeds directly into payment by results, the PBR system.
Which is huge for hospital funding.
It determines the trust's income for that patient's care.
Yeah.
So if the coding isn't spot on, the hospital might not get paid correctly for the work they actually did.
Wow. Okay, so let's get into the skills.
Yeah.
The sources say it's like needing fluency in 4 distinct languages.
Sort of, yeah. 4 key areas of expertise they have to master. First, and this is non-negotiable, is just deep medical knowledge. Terminology, anatomy, physiology.
You can't code what you don't understand, I guess.
Precisely. You need to grasp the medical situation, the procedures, before you even look at applying a code.
Okay, so medical knowledge is foundation layer 1.
Yeah.
What's next?
Then come the classifications. ICD-10, that's the World Health Organization standard for diagnoses, global standard.
Right.
And then specifically for the UK, there's OPCS-4. That's the national standard for coding surgical operations and procedures. Really crucial for that activity-based funding.
Okay, so ICD-10 for what was wrong. OPCS-4 for what was done. 2 down.
And the third, well, more recent and mandatory, is SNOMED CT.
Ah, yes, SNOMED. That's the really granular one, isn't it?
Extremely granular. It's less a classification, more a comprehensive clinical terminology. Think of it like a massive structured dictionary for clinical details in the electronic record.
So coders need to be almost bilingual, working between SNOMED and the classifications.
Effectively, yes, they're constantly navigating these different systems. And underpinning all this is just rigorous adherence to the national standards and conventions. Consistency is key.
So it's not just knowing the rules, it's applying them analytically, almost like being a detective.
That's a great way to put it, because clinical documentation, well, it isn't always clear. It can be ambiguous, maybe incomplete. So the coder has to investigate. They need meticulous attention to detail. We're talking pinpoint accuracy here. A tiny error, maybe missing one character in a code, can completely change the clinical meaning.
And the financial outcome, presumably.
Directly. Because those codes map to something called a healthcare resource group, an HRG.
Okay.
So a simple code might give you an HRG worth, say, £2,000. But if the notes actually supported a more complex code, indicating complications perhaps, the HRG might be worth £7,000.
Big difference. So what happens if the notes are unclear? They can't just guess.
No, absolutely not. That's where the detective work really kicks in. They have to use their knowledge, maybe look at other parts of the record, and if it's still ambiguous, they need to initiate a formal query process with the clinician who wrote the notes.
Right, which sounds like it needs some careful handling, asking a consultant to clarify their notes.
Exactly. And that brings us to another key skill, what the sources call clinical engagement and facilitation. It's about having those sort of soft skills.
Facilitator skills, yeah.
To collaborate with clinicians, not challenge them, but work together to improve the source documentation itself. Ideally, improving it at the point of care. It makes everything more accurate downstream.
So it's technical skill, analytical skill, and people skills. And then the final piece seems to be understanding the bigger picture.
Yes, the strategic understanding. Knowing how their coding decisions ripple outwards, how the code becomes an HRG, how that HRG links to the national tariff payment. They're essentially building the hospital's financial and clinical data story.
Wow. So looking ahead then, lots of talk about AI and automation in healthcare data. Is this role at risk?
Well, the sources suggest that yes, AI might automate the simpler, more routine coding tasks, but the human coder, they become even more crucial.
For the complex stuff.
Exactly. For the ambiguity, the complex cases, the quality assurance, technology will likely free them up to focus on the areas where human judgment, that analytical skill, and that clinical engagement are absolutely essential. The demand for those high-level skills will probably increase.
So clinical coder, part linguist, part detective, part diplomat, part data strategist.
Yeah.
Truly an invisible but vital architect.
Couldn't have said it better. Which leads us to a final thought for you, the listener. If AI takes the routine work and the really complex the coding that underpins the NHS's financial and clinical integrity still relies on human judgment, how much more valuable will those expert human coders, the ones skilled in QA and resolving ambiguity, become in the future?